Good afternoon, everyone, and welcome to our webinar. This is how to get GP buy-in for digital social prescribing. You're all very welcome this afternoon. I hope you're all safe and well. My name is Serena Terry. I'm going to be your facilitator this afternoon. And what I want to do now is just run you through a few housekeeping items. So if you can hear me and you can see my screen on the right-hand side control panel there, please raise your hand. And if I can also let you know, at any stage throughout the webinar, if you want to ask a question, we will be stopping for Q&A. But if you want to ask a question, please feel free to pop it into the questions box or the chat box. We've had an overwhelming response to the webinar today. There's over 380 people registered, so bear with us. If we don't get to answer your question today, we will get back to you within 24 hours via email. So I'm just waiting to see all of these hands going up there. Yeah. Fantastic. I'll just give it a few more minutes. If you're just joining, I'm just asking everybody to raise their hand if they can hear me and they can see my screen. Perfect. So your presenters today, first up, we've got Paul Gaskell, who's Head of Partnerships for Elemental. Welcome, Paul.
Thank you.
And we've got Mohan Sekeram, who's GP Principal at Wideway Medical Practice and also Social Prescribing Locality Lead from Merton CCG. You're very welcome, Mohan. We're delighted that you could join us this afternoon. So what are we going to run through today? Here is today's agenda. So we're going to kick off and give an introduction to social prescribing. We're very aware everybody probably already knows about social prescribing, but we just want to run over it briefly at a high level and talk about the benefits and why it's so important. We're then going to talk about the challenges for GPs. Whilst this webinar is very much about getting buy-in for GPs, there are a lot of other stakeholders like social prescribing link workers, commissioners and patients who rely on obviously GPs being bought in to social prescribing. So we'll talk a bit about that. Then we're going to talk about how Elemental helps, more specifically how digital helps in our digital social prescribing platform. So we're going to take you through the different referral routes and we're going to talk about clinical system integration. We'll talk a bit about SNOMED pushback and how you can do that in the Elemental platform. And we'll also showcase some of our reports and the benefits and the kinds of things that you can report on back to a commissioner level. Then we're going to round up with the high-level benefits of digital social prescribing for GPs. And then we'll pass you over to none other than Mohan Sekeram, who's going to talk about social prescribing and why he, as a GP, is bought into it and why it's so important to him. And he's going to go through the Merton model and talk a bit about what they're doing at Wideway Medical Practice. Then we'll round up with the Q&A as mentioned. So without further ado, I'm going to pass you over to Paul Gaskell, but before I do that, I want to set the scene and ask you guys to answer a little poll for me. We want to hear from you. What is the main barrier for you in your job role to getting GPs bought into digital social prescribing? So what I'll do is I'll launch this poll and I'll give it a few minutes for everybody to answer. And that essentially is going to help us to set the scene and see the areas that we need to focus on throughout the webinar. I'll just give that a few minutes. And if anybody can see me on the camera, you'll probably notice that there's a Santa above my left-hand shoulder, and I am also holding a Christmas mug. Can you guess that I love Christmas? It's 2020. We have to do what we do to bring some cheer this year. So yes, I am a premature Christmas decorator. So apologies if the Santa here's making your eyes sore. I'll give it a few more minutes for this poll. And then what I'm going to do is I'm going to close the poll and I'm going to launch the responses so that everybody can see. And I want to ask Mohan and Paul, what do you think there? So 44% are saying that evidence that digital social prescribing creates benefits is one of the main barriers to getting GP buy-in. We've got 27% for too many digital systems already, 20% for time to review the evidence is a barrier, and then 8% funding. Paul, I'll ask you first, what do you think of that? Is that what you expected to see on that poll?
I guess I expected the funding one to be a greater issue because I do feel like there's lots of evidence out there now for the benefits. So that's as positive. That's a good outcome, because we certainly look at that. But yeah, so it's not what I expected. No.
Okay, Mohan, what do you think?
Yeah, I probably did expect that, actually. I think a lot of people don't quite understand it, and as we'll find out later, they know what social prescribing is, but they're not sure why they're doing it. So hopefully we'll explain why we're doing it and why there's benefits, and that will then hopefully show the evidence, which there's also some evidence later as well. So yeah, no, that's a good poll. Thank you.
Perfect, thank you, Mohan. And if the barriers that you feel are evident with getting GP buy-in to digital social prescribing aren't listed there in our poll, please feel free to pop them into the questions box, because it's good feedback for us as well. And I'm sure there's more than one. So what I will do now is pass you over to Mr. Paul Gaskell. Paul, it's over to you.
Thank you. Thanks. So firstly, a big thank you to everyone for attending today. We are fully appreciative of the demands you're all under at the moment. So taking an hour out of your time is a big ask. So I've locked my partner and the dog in a cupboard somewhere, so they don't come and turn the kettle or the washing machine on. And hopefully there'll be nobody waving over the fence, so we won't be distracted today. So I'm going to run through a few slides. I'm kind of the warm-up act, really, and then you've got the headline act in Mohan following on shortly. So what is social prescribing? I've got my little T-shirt on, which I think kind of sums up. Don't medicalise, socialise. This is a lovely Mohan's T-shirts, and other sizes and colours are available. And I guess it's often been described as the community development approach to health and well-being. And we know there's never been a busier time for you link workers with the current pandemic. It's been, I mean, I was thinking the other day, a lot of these projects kicked off, you know, at the start of this year, or link workers were employed at the start of the year, and that, you know, no one could have really foreseen. You were all just kind of settling into your roles and learning your job and your areas and kind of engaging with your GPs, and then you know, the pandemic hit. So it was kind of unprecedented, and the way that GPs and the link workers have kind of maybe repurposed themselves and responded to the demand for this pandemic's just been amazing. So we've got a slide here that just shows kind of some of the changes since the start of the pandemic, really, which has been huge. So we look at the increase in demand for social supports. You can see on our platform we've had an extra 24,190, so 64% increase since the start of COVID. And we know that number is obviously a lot higher. It's just, you know, the way people have been working sometimes to respond to the pandemic. It's been quite a light touch, so people have just had a quick call, and then so not everybody's been on the system as such. When we look at adoption of digital technology to help deliver social prescribing, we've had an extra 516 link workers starting using the platform since the beginning of COVID. And then what's been just a crazy figure, really, is the number of health professionals, so the numbers of GPs, nurses, practice managers, etc., that are making referrals through the system. So we've had 3,716 new referral agents added on. So now 7,429, so 100% increase, which has just been crazy. So yeah, next slide. What's really been a help for clinicians has been the integration piece. And you know, EMIS wise, we've been working with EMIS for a long time now, so that the ability to make the referral within a few clicks in the clinical system was really important. You know, we know how busy clinicians are, so to move to another system was never going to be ideal for them. So we enabled that referral from EMIS and the ability to click back in and have a little overview of what's happened after the patient left the room. You know, it's nice for them to kind of have that feedback loop. And where we're at the moment is just completing the pushback. So Barnet and some areas of Manchester are just in testing that kind of SNOMED pushback. So that's going to really support the GPs with their reporting for the DARES. Vision. So Cardiff spearheaded our integration with Vision, and they're now their GPs across the Cardiff area are making referrals, and we're just starting to work on that pushback in the Vision system as well. When I talk about pushback, sorry, I mean that SNOMED code back into the record. And then System 1, so Hounslow in London have really helped us with the testing for the System 1 integration. So now System 1 GPs can make referrals within a few clicks straight across into the social prescribing projects, and we're just working on the in healthcare pushing that SNOMED code back. And when we look at the EMIS, you know, it really does help having that integration. I know one of my customers, Harrow, when they first started, really took them a while to get all the GPs connected and on board, but you know, we've recently seen that their referral target was hit you know, way early in their contract, so they've really found it a help. One of my newer projects, Lambeth, they're at that earlier stage, and they're just, you know, running workshops and sending things out in the newsletter and getting that whole kind of the buy-in from the GPs, and we've already started to see those referral numbers increase as they get switched onto the system. So next slide. I just wanted to just touch on who uses Elemental, and when we talk about the referrals, obviously it's historically always been the GPs making referrals, but increasingly social prescribing is used across all sorts of industries now. So we've got a new project in Glyndar University. I'll get shouted at for saying that wrong, but in Wales. So for student health, you know, health, housing, the voluntary community sector and government, they've been, you know, across the board been using social prescribing for many a year. But, you know, prison health is a new one for us, and more recently employability. So we've seen in the mini budget, the Chancellor announced that there's going to be some support for people who have been on benefits and out of work for a number of I think 13 weeks or more. And so we're really excited to be working with Ingis across London and Manchester, well, the Northwest, on the JET scheme to support people back into work as well. So what do? We have a cloud-based digital platform, and what that means, we can kind of run that end-to-end project for you. So everything from the starting point where those referral agents, those GPs need to make referrals. So GPs want to connect quickly and they want to connect securely, so they need a trusted system. What they also need now is for their link workers to be able to be remote. You know, we've noticed with COVID, I had one client I was speaking to who, when the pandemic hit, they found that all the link workers are at home and all the files were in the office, and it's really difficult to share that information. So all you need is a Wi-Fi connection, a laptop or an iPad, and you can have your staff working wherever they may be. So those link workers use the system to manage the referrals, their caseload, measure the impact, which they can report back to their clinicians, and the system will soon be auto pushing back those codes into the GP system as well. And also, you know, we kind of manage all that kind of IG GDPR compliancy as well. So I'm just going to quickly look at the COVID response flow. It's a lot's changed in the last 8 months, and so GP referral, you know, that's been happening for a while. You know, those integrations have really helped. But we found that, you know, to really support GPs during COVID, they didn't have the time to manage all the referrals. So the introduction of self-referral is great, and we're going to see more and more projects taking that self-referral route. So, you know, I often refer to my London projects. Apologies, because I'm based in the south, but I know in, you know, One Health Lewisham, it's been really helpful for them having those referrals coming directly from the GP websites or the council websites, wherever you want that to be coming, and just to take that demand away from the GPs. We've got that kind of express referral, so the ability for you to set anybody up as a referral agent with a login to Elemental, and they could be an ambulance driver or a pharmacist that wants to refer across into the project. More and more we're seeing social prescribing projects want to refer to social prescribing projects. You know, we know that they recognise there's a specialism in another service, so they want to be able to all join together. So you know, that's kind of increased, and then crisis support and secondary care also wanting to refer across to social prescribing. And what that just shows is that everybody's increasingly seeing the benefits of social prescribing. So the referrals will come into the digital platform and allow the link workers to manage their caseloads, and they're able to do that from home now. They'll be able to pick up those referrals and make the one-to-one assessment, more commonly at the moment via telephone. And then they can assess what's required, and they've got a whole range, you know, and we see the directories growing all the time of the different types of activities out there, often now moving to more digital online activities, but you know, things like crisis support, food banks, etc. have been you know, really widely used through social prescribing over the last few months. So once the assessments have happened and some data is being captured, we have the ability then to measure the impact. Now, as an organisation, and we've been able to measure the impact on patients for a long time. So there's a number of tools in the system, you know, some of them such as PAM, SwemWeb, you know, more recently MyCore, that just can take that baseline metric and then monitor change over time. We've also, for many a year now, been measuring the impact on community. So a project being able to know why the referrals are coming, which GP practices have got the highest demand, where's that referral coming from, and reasons for referral, and then where are they referring on to the community, where are the gaps, so where do they need to maybe commission more groups and services to be run. And where the newer area is this kind of health and social care system, the impact on the system. So we're doing a piece of work at the moment with Merton and Wandsworth, and they're kind of one of the first to be looking at that data, that secondary care, that SUS data, and that primary care data. So what impact is social prescribing having on hospital appointments? What impact is it having on GP appointments? And we're able to do that now through the extract of our data. So they'll take the data of ours and go and do fancy stuff with that in their own data warehouses, and also the pushback of that code into the GP record will help with that as well, because reports will be able to run in the clinical systems as well. Next slide, please. So just quickly then, before we move on, so just some of the challenges we solve really. So for GPs, they need to deliver on their PCN DES funding, so they want that ability to report on their referrals that they've been making, and they want simple referral pathways that are quick, a few clicks to get it, you know, across to the team, the trusted team they have there. For patients, you know, more and more we're seeing patients with multiple social needs, so they need that extra support, but they don't always want to go to the GP for social prescribing referrals. So they're now able to make that referral directly from maybe the GP website, so they can bypass the GP as such and save on a little bit on that demand. For social prescribing link workers, they don't always want to have to come to the GP practice to work. They want to be able to work remotely, you know, work from home. And obviously they've got a requirement to report on that DES as well, so the ability for the system to automate that for them, just push those information back into the clinical systems. And then for health, housing and social care commissioners, it's always been data. Every meeting we have is data, so you know, justifying, you know, expenditure and looking for those gaps in provision as well. So the last slide for me then, just so some of the benefits for GPs using digital, they can deliver on their social prescribing objectives. So the report on social prescription offered and social prescription accepted, they're the SNOMED codes. They can support more patients with non-medical social issues by the ability to refer from within their clinical system. They can access safe, secure, effective referral pathways. They have the ability to monitor the impact of social prescribing referrals using some of those monitoring tools that we mentioned. They've got the ability to access a number of programs, support initiatives in the local community, and they can empower patients to access link worker support without having to come into the practice themselves. So I think that's my last slide, and I can have a breather and pass over to the lovely Mohan. So thank you, Mohan.
Thank you, Paul. Are we going straight on?
Yeah.
Carrying on?
Yeah.
Well, thanks a lot for inviting me to come and speak today about social prescribing, and love the T-shirt, and I've got my other one here, which is "Don't medicalise, personalise." So that's the new edition. But yeah. So thank you for asking me to come again, and I want to talk about how we get buy-in. And for me, it's really interesting, that poll which we did at the beginning, which looked at why it wasn't working, and it was around the evidence. And I think it's really important that we find out why we're actually doing social prescribing, and that will really, if you get it correctly done, then you'll get the results at the end of that. So first slide here, we've in Merton and Wandsworth, we're doing social prescribing. Just a couple of pictures there which just showcase us wearing the T-shirts and also advocating for that, which has gone a long way. Yeah, if we go to the next slide, please. So what I'm going to do the next sort of 20 minutes or so is just talk about why we're doing social prescribing, the model in Merton, how it works. I'm a GP in Merton, how it fits into the long-term plan, and how it works with the primary care networks and getting buy-in from all the stakeholders. So it's not just about the GP having a social prescriber, it's about how that integrates with all the other elements in the system. I think that the biggest problem is that we think it's just primary care focused and it's just general practice. It's not. It's everyone involved, and that's the first key message. What opportunities there are, what challenges there are, and how it fits into the now personalised care, which is the long-term plan. So I've got on the right here the golden circle. Sorry, if you go, and that's the golden circle. For those who aren't familiar with that, have a look at Simon Sinek, which is a TED talk. And he talks about how we do things and how to get the most effectiveness out of anything you do. And quite often, a lot of companies will understand what they do, which is the outside of the circle. They'll understand how to do it, but they won't understand why they're doing it. And what happens then is whenever they get problems, they don't know how to overcome them. So in any successful company or any successful venture, you need to start off at the center. So why are you doing it? If you've understood why you're doing something, you can then deliver how to deliver it, and then you'll get your results, which is what it is. And an example of that is, everyone sort of feels they know what social prescribing is. Oh yeah, it's a link worker. Oh yeah, we'll put it into a practice. But what happens after a while? It doesn't work, and they don't know how to react. But I think if you work from the other way around, it will put you in good stead, which comes back to our evidence. So next slide, please, Serena. So what is social prescribing? So why are we doing social prescribing? So there's lots of factors which affect health and well-being in patients, and one of those factors is social factors. So things like housing, debts, benefits, social isolation, employment. And often if we don't sort out that root cause issues, what will happen is that individual will start getting physical symptoms, so a headache, a rash, feeling tired, and they may then see their GP saying, look, I've got this headache, I've got this rash, can you help me? And we may go, great, yeah, in our 10 minutes, we may medicalise that problem, and the patient will be relieved. But actually underlying it is their social issue. We won't have time to tackle that underlying problem. And it's estimated that 20% of patients who see their GP actually have a social root cause issue. And so there's big numbers there. And those social issues are dependent on the determinants of health. And what social prescribing, why we're doing it, it allows GPs or other healthcare professionals a non-medical option. And so it shifts that model from the medical model to the psychosocial model. So on the right there at the bottom, we've got a map of Merton. So on the darker side is East Merton, which is where my practice is, and it's more deprived, the darker areas. And certainly here we have some real social needs. And so this is why social prescribing has worked and why we're finding such benefit for it. Next slide, please, Serena. So again, some further whys. Someone who presents with depression, underlying that is it bereavement. So if you don't sort out the bereavement issues, they'll keep coming back with depression. We may give them antidepressants, or we might sign them off sick. The one below it, heart problems. If someone comes in with heart problems, we may refer them to a heart doctor, but actually underlying it, is it the financial concerns? We're not going to be able to sort out all the financial concerns, but at least we'll know someone who can help solve that, or help take the pressure off. And then right at the bottom, recurrent infections, absolute classic in primary care. Someone keeps coming with infections of their legs, so fungal infections or skin infections, and we may give them antibiotics and treat the infection, but actually underlying it, is it a housing issue? Is it damp? Is it overcrowding? Is it sort of dirty? Is it things which need social cleanliness? So if we could move on to the next slide, please, Serena. So I've talked about why we're doing social prescribing. We're looking at some of those social issues which need tackling, and so they're non-medical, and so we want to try and not medicalize it. So how do we approach this? So historically, we will know that some of these patients need social support or help, and I may refer them to a link worker outside the practice, or I may refer them to an Age UK or Women in Guild or Citizens Advice Bureau down the road. As soon as the patient leaves the practice, they then think of other things to worry about or do, and so you often may lose them. And how this works is that you're linking the link worker in the practice, so they're part or embedded as part of primary care, and that's a really, really big difference, because before you were sending the patient outside the practice, but now you're actually having them in the practice, and that's what the real how to really get engagement. So, and that's really key. So if we can move on to the next slide. And the how practice is that the link workers embedded in the practice, they're part of the team. So they don't come in, do their session, and off they go. They turn up to staff meetings, clinical meetings. They make tea for other members of staff. No, but they're around, and actually they feel part of the team, and they feel they can go and have informal conversations, catch up with the receptionist, and that's like any member of the team. So that's how you truly embed them as part of the team member. And so a GP, or now we've moved it out to nurses and receptionists, will fill in a referral form, which is now an Elemental. So electronically we'll fill that in, which is much quicker. You can do it on 3 clicks. They'll also give a social prescribing booklet to the patient, and then a link worker will then see what's happened and then advise the signpost. What's great about the link worker is that they will leave their footprint on the patient's notes, so the GP can see what's happened and the link worker can see what's happened historically. So we've talked about why, we've talked about how. If we can move on to the next slide, please. So if you can get those 2 right, then the evidence will come. Now, if you haven't got the why and the how bit right, then no matter what you do, you're not going to get the result. So this is what we had in Merton. So qualitatively, we were looking at the wellbeing star when we started 2017, and you can see there we had the wellbeing star as a measure of their wellbeing, and we had a significant improvement in scores from 2.8 to 3.5, which was significant. And so that qualitatively showed us that this does work. We've also got some videos quantitatively which help as well. We're now using PAM as per the long-term plan, and we've shown similar data as well. We haven't quite finished that, but that will be coming out soon. Next slide, please, Serena. So another what. So if you get your why and the how to do it right, this is another measure. So this is looking at patients who saw their GP before social prescribing and after social prescribing. So a bit of a busy slide, but if you look at the one with the red dots, you can see there that a patient right at the top, you can see a dot, that a patient saw their GP 55 times 3 months before social prescribing. And you can see the spread of other dots as well. They then had their social prescribing intervention, and then 3 months afterwards, you can see the blue dots, how that reduced down, and you can see a nice reduction from 12 down to 8. So you're really identifying these complex patients who have complex needs, who take up a lot of primary care time, not because they don't know, not because it's wrong with them, they don't know where to go, and we're not managing as well as we could do. So actually, we're then opening up a massive resource in primary care, because actually we're dealing with the patient in the right way, they're having the right conversation with the right person. So on the right there, we've got some numbers. So we saw a reduction of 543 appointments and a reduction from 12 to 8. And again, these are complex social needs issues which we found of great benefit. Next slide, please, Serena. And so again, another what, we saw the same pattern in A&E, so a reduction in A&E appointments or attendance to A&E after 6 months by 50%. Next slide, please, Serena. And so we looked at our social prescribing service. So again, more and more data here, more evidence here. This goes up to March 2019. And again, you can kind of see there, the blue dots shows the number of savings we made. And as you can see, as the year went on, it went up. And the green bar charts are the number of patients which we referred cumulatively. So again, the more referrals, the more savings we made. So makes sense, hey. But yeah, you know, this, and that was just for, so in Merton, we started with 2 practices, that went to 9, then 13, and now we're in 22 practices. And that only started in January of this year. So this is March 19. So we only had about 13 practices on at that point, and we saw some great savings then. So at the moment, we'll see bigger savings. Unfortunately, COVID has had an impact in terms of how we analyse the data, but that will be coming out soon once we've tidied a few things up. Next slide, please. And again, this is also reflected in some other studies across the UK as well. You know, these all showed reduction. These are really good evidence data, and we based a lot of our model on the Rotherham study. Thank you, Serena. Next slide, please. So I'd like to talk, so we did some qualitative analysis with the wellbeing store. We looked at quantitative about GP appointments and A&E appointments. We've also got a video. I'm not sure we're showing that now, but there's some videos as well which also really help you know, get buy-in. You know, this is what happens, and this is how it impacts on the patient's journey. And we've got a great video which has got 5 patients, and they're all very different: old, ethnically mixed, young, and all very different social situations. And actually, you show that to a practice, you'll then realise actually I can relate to that. That's where I need to be, you know, focusing my care. So anyway, this patient here, we've got a patient B in the middle there with the red apron. He was seen at our practice for depression, and we were giving him antidepressants, and we were giving him his medical certificate every month. So he would come in, we'd give him a certificate, we'd give him his antidepressants, and that would be his treatment, and we would collude with him. And we didn't really get anywhere, did we? Then we identified Ray. Ray started work at Wideway. He spent some time with Ray. Ray identified that he used to work as a chef in his previous work, and he actually just wanted to work. He managed to get him a job at the local community centre, and there he is in the middle of the picture with his hamburger and chips. It's not quite gourmet, but you know, it was a job. So he didn't last so very long, and then he moved further down to a local cafe. And so he's now working there. He's giving us our lunches, and I'm on my home visits. I drive past and get my sandwich. And so this is someone who we were seeing as a patient with antidepressants, sick notes in the periphery of our community, and now actually has got a role in community, giving back, and is a central, you know, important member of the community. That does wonders, not only to him, it builds his self-esteem, his resilience, and also the community, but also as me as a GP. You know, I'm no longer seeing this patient medicalising him. I'm now, you know, getting my sandwiches from him, and that's really empowering for my own health and well-being as well. Whereas before, I was just doing the same thing. Yeah, next slide. So, you know, COVID. Obviously, we need to talk about COVID because, you know, the gap has widened, and you know, we need to support and integrate with our community. So, how have we done that? The link workers have been phenomenal. And if there was, you know, the work I've explained to you before was all pre-COVID, and now COVID's happened, we found even a bigger niche. So patients who are vulnerable, patients who are hard to reach, a lot of voluntary sectors have had to adapt their services, and our way of communicating with them are via our link workers. So all the link workers have been remote working. They have AccuRx training, which is a medium to do video consulting. And some of the stuff we're seeing, as you've all been seeing, are welfare checks, emotional support, domestic violence, massive in lockdown, housing issues, homelessness, alcohol as well, I should put in there, as well as drug. The link workers also attending MDT meetings and liaising, so they're really integrated as part of the team, and also mental health training and coordinating with volunteers. So, you know, a real massive role there, not just in the primary care interface, but also connecting with the community. Thank you, Serena. So how to get buy-in from primary care? So 4 years ago, or 3 years ago when I started doing this work, a lot of people were asking, what are you doing? You know, are you wasting your time? but actually, you know, I showed them the video, which is available on YouTube. I showed them some of that data, and suddenly they're like, wow, when can we have that? And I think actually explaining to them the why and the how bit and how it can work gets you your results. And then suddenly you get buy-in, suddenly you get the FOMO, the fear of missing out. So they see how it's going to work. And I think a lot of general practice and lots of doctors are very busy, we're all busy, but and you don't want to adapt to something new because there's so much going on. And so I think it's empathizing and understanding what the need is, and then showing them some of this fantastic data. So, and that's what I've explained there. So the easy referral, embedding in primary care, looking at some of the data, and also feedback and outcoming. So when your link worker works in the practice, they're not just left alone to their own devices. It's really important to have supervision. It's really important to catch up with them and find out, you know, what's happened, what's worked, what's not worked, how can we improve the service, etc., etc. Thank you, Serena. Oh, and that T-shirt was we did a lot of the doctors got together, and there's another range called Don't Medicalise Exercise, which is a light blue t-shirt, and so we did a 5k run and raised some money as well. So primary care networks, so this one is looking at what it was for year 1, and now for year 2, which is where we are now, is trying to link that forward. So that's a slightly older sort of description on that, but I'm going to talk about that a bit more when we talk about personalised care. Next slide, please, Serena. So what can the link workers do? So create personalised care plans, looking at diabetic input, health coaching, dementia awareness. Again, it depends on what the need is in your area. So the graph, the map right at the beginning, we had a deprived population which looked at social needs, and certainly in some of the affluent areas there was more of a need towards dementia awareness and home visiting. So it's knowing what you need them for and getting the link workers to support that cohort. And then, yeah, social determinants and embedding into MDT teams. Lots more opportunities as well. So how do you get buy-in from the voluntary sector? Really, really key that you include them in your journey. As I said, it's not just about primary care, it's also the voluntary sector and the local authority. How will it impact on the voluntary sector? Align with the services, not compete. A lot of voluntary sector services say, well, we're doing social prescribing, why don't you give us the funding? Or they didn't quite understand it, and so you need to make sure that it links in with what's already there. Whatever your assets are, don't compete with it. Make sure you grow it with that. And you need to ensure that you identify funding for the voluntary sector, because effectively you're getting 20% of patients that see primary care, and you're kind of lifting and moving them to the voluntary sector. And if you don't support that, they may blow over, and it's going to be increased demand, and therefore that really needs to be thought about. And also volunteer staff as well. Thank you, Serena. So this is great. So last year we did Rough Runner. Paul's going to do it next year, he's promised me. But there you can see, the whole team in Merton there. We've got members there from Age UK. We've got policemen there. We've got our CCG chair. We've got our Federation chair. We've got our Barry, who's our local authority strategic lead, and we've got some other voluntary sectors as well as some GPs. And that really showed together how it's worked together to get this through, and it makes our conversation so much easier. We raised 3,000 for Merton Giving, which is a local charity which gives to the voluntary sector. Thanks, Serena.
If I'd have joined you, Mohan, though, I'd still be on the course. I'd have missed the photo opportunity. I'd still be finishing now.
We should be there making us tea at the end, I think.
Yeah.
And the other one is buy-in from the council as well. So yeah, a massive part of the jigsaw. And actually, it was actually Barry from Merton local authority who actually approached me, or approached all the GPs, said who's up for getting involved, and I put my hand up, and the rest is history. So actually, buy-in from council. What is the strategy? Focusing on community. They're doing the same things, and actually, it needs to align that. And we managed to get our funding together, building network connectors. We got some funding from the Better Care Fund. We started in 2016. I joined, so social prescribing in Merton started in June 2016, and I joined the party in 2016 in August, and that's where I got involved. And the magazine on the right there is the council magazine, My Merton, and again that shows wonders that we were talking about social prescribing as a GP in primary care, making a magazine for the council, and that was fantastic. That gives a really good message, getting buy-in, not just from primary care, but also from the local authority and the council. Next slide, please. So what factors do you need to support a scheme? So talked about it again, I'll go over again. So collaboration, engagement with stakeholders, getting the right people there, identifying what your needs are. So is it deprived, affluent, young or old? JSNA is very useful at finding that out. And making sure you have a steering group to drive it forward, and get the composition right as well. Evaluate it, and certainly the DES will help support that. Things like GP appointments, A&E appointments, and also wellbeing scores or PAM scores are really important, not only for the commissioners but also for yourself. You need to work out how is this working, and then getting some support for the voluntary sector and the social prescriber. Thank you, Serena. So some of the challenges: getting the right model, making sure that not seeing the full benefits, so it takes a while to embed. And I think one of the problems we're seeing at the moment with networks is that there's a real rush to get link workers in and kind of get on with it and do it. But as you can see from our journey, it's taken us 4 years to get to where we got to, not 4 months. And I think that's an additional pressure for networks at the moment. So be patient, make sure you get the right ingredients involved, otherwise you may struggle. Getting engagement from the voluntary sector and supporting the link workers and also the voluntary sector as well. Thank you, Serena. So opportunities, pledging money to get 1,000 link workers by the end of 2021, which is coming up soon. I think we're close to that actually. Integrating with the community, promoting health and wellbeing and reducing health inequalities. And the health and wellbeing is not only for patients, but also the clinical staff who are able to help these patients. Reduce impact on primary and secondary care, massive. Health and wellbeing practitioners. Personalised care. I'm going to talk about this, and then I think that's the home stretch. I mean, the personalised care is one of the 5 big long-term plans, and it was going to be implemented in April this year, but it's going to be a DES next year. And it's it's really important to give patients choice and control of what matters to them, and it looks at everything as a whole system rather than looking at just one area. Next slide, please. And it has 6 enablers which allow us to do that. And as you can see, the circle's kind of moved, but you can see that social prescribing is the bottom left box, which is what we're talking about. You've got supported self-management, personalised care, support planning, and shared decision making, and personal health budgets. So I won't divulge too much into that, but I wanted to give you a flavour that social prescribing sits in under the personalised care offer. So shared supported self-management, how can someone help support themselves? And this year there were these roles, these ARS roles as part of networks, and these will really complement the link workers. And I think I want to make it clear about what their distinct roles are. So a social prescriber helping to support patients and understand what some of their social needs are. They will have an understanding with a bit of health and wellbeing coach and a bit of motivational interviewing. However, the health and wellbeing coaches are purely that. So they're looking at what are the needs of a patient and what will help them get them the care they need by helping or evoking behavioural change. And so, for example, you may have someone who's diabetic who may not be taking the medications, and why they're not taking the medication. So it's sitting down with that individual, finding out what would make them change or what would matter to them. And that's where health and wellbeing coaches can become really important. And they'll use the PAM score, so the patient activation measure. Someone who's lowly motivated would really benefit from a health and wellbeing coach, where someone who's highly motivated may benefit from self-supported management, and someone who's middle of the road could do with either or maybe some social prescribing. So that's where that all links in. Next slide. So this is how they work. So you've got your social prescriber, your care coordinator, which is another role, and the health and wellbeing coach. So they all link in together. So the care coordinator going through a care plan with someone, helping support them understand what's happening in their care and maybe answer any questions or link them back in to the link work or health and wellbeing coach. Social prescriber and the health and wellbeing coach. So really valuable resource, and I'm really pleased that that's part of the personalised care offer. And the care coordinator, which slightly mixed around, but so this is the other role, the other care coordinator role, and that's another role where they would be able to sit down with an individual and talk through their care plan. Do they understand it? Diabetes, for example, do you understand what HbA1c means? Do you understand what the doctor's been doing all these years? Do you understand what you need to do? What would you like to do? Etc. etc. So I think it's aligning that a really exciting time, and so I think getting buy-in for me, if I just reiterate, is about understanding why is it you're doing it. If you don't understand why you're doing it, it's not going to work. You then can't offload that, get engaged with other people. And then there's Paul posing there. I think we had lots of tweets with that, or lots of likes. I think like the sales of those T-shirts went up through the roof after that shop. And then on the right, that's our friend, our depression friend, who is working at that cafe, and he's now a Facebook friend of mine, which is great to see. I see him having lots of fun at the moment. But so yeah, so happy to take any questions.
Perfect.
Mohan, thank you. Mohan, on that
T-shirt's a little bit tighter since lockdown, I have to say. I wasn't quite sure if I'd get into it. Be having too many biscuits with my morning coffee, but thanks, Serena.
Well, at least you have one. I was going to mention there, Mohan. I haven't seen my T-shirt yet, but it must have got lost in the posts. But anyway, we'll go on and answer some questions. So Mohan just mentioned there that there's a video, a YouTube video. YouTube and GoToWebinar don't play well together. So what we're going to do is when we're sending out the recording of this webinar, we're going to send out the slides and the link to the YouTube video as well. As Mohan said, it's a great asset to be able to send on in terms of evidence and trying to get buy-in. Couple of questions here. There's one specifically about funding and how, Mohan, in your experience, what's the best way to get funding for a digital solution? Mohan, I'll go to you first for that one.
For a digital solution or social prescribing in whole?
This is from Fiza Ahmed, and they are in Manchester. They have a social prescribing program. So they're asking what's the next step in being able to secure funding for software.
For software. So, so I think it goes back to the original thing about your steering group, isn't it? So whatever your composition is in your area is finding out what your needs and your assets are. So you need to have a conversation with your public health or your local authority or your voluntary sector, and then identify, what are we going to, how are we going to drive this forward? In Merton, it's actually our voluntary sector provider who then procured the digital software, as was in Wandsworth as well. They also procured it as well. I know other areas where the CCG have done it. I know other areas where the Federation have done it. And so it depends on what the lie of the land is in your local area. So I think it's work out why you're trying to do it, and then work out where the funding is and making sure it matches, and making sure that you have some measurables at the end, some targets to aim for, and go for it. So yeah, that'd be my advice really. I think yeah.
Paul, do you want to add anything?
Yeah, I think you're right, Mohan, and I think it's really important to try and get as many stakeholders around the table as early on as possible. So you have buy-in from the local authority, CCG, housing associations seem to be really involved in social prescribing within areas these days. So and sometimes have some funding there to support parts of social prescribing. We certainly saw that in the likes of Ealing, and we've spoken to some of the housing associations in Merton as well. So I'd say just try and get all the stakeholders around, and also watch out for funding bids. There's always funding out there. There's different pots popping up all the time to support social prescribing. We've got a lovely lady called Helen who is always looking out for funding bids for customers who say, oh, I'd love some digital, but we just don't have the funds. So, and then we can keep in touch and support that.
Thanks, Paul. We have another question here from Matt. Matt says, the voluntary sector is very diverse. It ranges from national organisations to small local groups. Matt wants to know, what quality assurance guarantees do social prescribing link workers look for in a delivery organisation? Mohan, I'll go to you first on that one.
So what quality assurances do they have in terms of making sure that what they're delivering? Yes, that's a very good question. Again, goes back to what have you got in your area. So again, in Merton, I look back, we've got a MBSC, which is Merton Voluntary Service Council, and they oversee all the all the charities in Merton. Some are very big, and so they are there as a sort of safeguard to support them, support with funding, support with assurances, and ensure that that things have the right quality checks. I think part of the link worker's role. So the link worker spends 5 days in our network, 4 days in practice, 1 day back at headquarters. So it's the one day back at the sort of MBSE camp. And part of their role is to kind of then feed off the other link workers to find out which services exist, which services need support, which services are open, closed. So I think it's that continual work driving forward is how you kind of get the quality assurance and ensure that we've got safety across the patch.
Thanks, Mohan.
I think it must be. I was thinking it must be so difficult now with COVID that they can't be out there in the community as much as they used to be meeting these services, and because I'm sure that played a big part in the quality assurance is going out there, meeting these services and seeing them going along. And I mean, I always come at these from a different angle to Mohan, because I talk about what I understand in our system, and so we have things built into Elemental that can help you mark when things are being quality assured, and just set those reminders to check maybe 12 months down the line to see if this is still active, so that you can switch activities on and off in the system just to see. But and some services I've seen will have certain documents that they'll require from different activities, maybe one they've created themselves to say that they adhere to certain things. But yeah, it's a really good question.
Thanks, Paul. Mohan, another question for you. Scott Watkins is asking if you could possibly explain the difference between the care coordinator and the link worker a bit more. Scott says it sounded like the care coordinator was doing a lot of things that he thought the link worker would do, for example, brief intervention, demotivate and set goals.
Yeah, good question. So I think I jumped it up in my slide deck. I kind of threw a couple of Googlies there. So for me, this link worker is looking at some of the social determinants of health, or looking at some of the social needs of a patient, and then addressing that. And so they will have an element of care coordination and they'll have an element of health wellbeing coach, but primarily they're looking at the social needs. And this is how I look at it. And I think this will be very different for every network across the everywhere. So it's really important that one size doesn't fit all. So what is your need in your area? What are your assets? And make sure it works. I see the care coordinator looking at doing one or two things. So I think they can then run lists of searches on patients and finding out which ones needs a certain support. I see them also as then linking them into link work and saying, look, I think you need a social prescriber. I think you need a medic. I think you might need a health and wellbeing coach. And so I see them as doing that kind of fact-finding search initially to see what needs to be done. And they can look at some of the medical cohorts. So in my practice, I'm giving them a list of dementia patients, learning disability, and finding out the care coordinators can go to do that initial triage and then find out where next to go. And I think once that intervention is done, the care coordinator will then pick it up afterwards and then speak with that individual and find out, look, do you understand what's just happened to you? If you have, great, and I'll see you in 12 months' time. If you haven't, then I'll refer you back to someone else who might be able to go over it again. And that's that shared decision making and allowing them to have that self-supported management. So again, it's very different what your needs are. There is a slight similarity between the three roles, but you can break it down or tease it out even more to make it work for your network or your practice. I don't know if I explained.
Marcy is asking, how do the digital assets or the digital software, how are they evaluated before the GP can accept it as a suitable intervention model? So suppose it maybe goes back to what we asked in our poll about evidence. What is the process to be able to present potentially digital software that could benefit them? What's the evaluation process, and is that something that you had to do before Elemental was brought in?
I'm not sure I understand. Sorry, is it asking about how we might use digital to support social prescribing, or how we may use it as a tool,
yeah,
or a bit of both?
Marcy's asking, I think it's a bit of both. She's asking how it's evaluated before the GP can accept it as a suitable intervention model. Marcy, if you maybe want to. Marcy, if you want to elaborate on that a bit, as I said, if we don't get to your question today,
listening to that question, Serena, I'd say that's very similar to the last question. I think we're talking about quality assurance here and knowing which interventions potentially. Marty may expand on it. I can't see the comments, but I think that's probably a similar question to the last one.
Okay, perfect. We've loads more coming on. Don't worry.
And we can come back with answers. After this as well. I'm sure there's lots we need to answer, so we can get in touch and help answer that question. Sorry.
I think the digital bit is, everything's digital now, isn't it? So I think it's a case of we need to get on and do it, as opposed to will it work or not. I think that we're turning into a digital world. Certainly COVID has made that happen even more so now. And so I think that's kind of our push to kind of make it happen. And so we're here now, so let's do it.
Yes. And it's been amazing what we've seen happen, isn't it, in these last so many months. The amount of people have been talking about doing things digitally for a long time, and suddenly, we internally spoke about kind of training online for a long time, because, and then within 2 weeks we built a training academy, so some small bits of good came out of this, I hope.
It's definitely speeded up digital transformation massively. Mohan, we've time for one more question for you from Kasim Manjang. As a social prescribing link worker, Kasim's asking that many of their colleagues find it difficult to find their feet in surgery sometimes within a team of staff. They're asking, is there any means to establish a good working relationship between social prescribing link workers and the rest of the teams? to be recognised as part of that team. You touched on that briefly in your slides there, but any tips in order to embed a bit more as a team rather than a standalone social prescribing link worker?
Yeah, and I think this goes back to the original part of the presentation, was the why bit. You know, why are you getting these people in? And if you're getting them in to just do a role and off they go, then that's not quite going to work. So I think it's really key that when they come in to post and where you're working, it's embedding into that primary care environment. So you may not be a link worker, you may be a receptionist, you may be a healthcare assistant. Doesn't matter what role you are. If you're going to work somewhere and you're trying to truly embed, you need to understand the environment. You need to understand what works. You know, when a coffee room is, when staff room is, how people interact. You know, what it's a big step moving to primary care if you've never been in there before. And so, you know, I would probably ask for looking at clinic. You know, whether you can attend clinical meetings, whether you can attend staff meetings, whether you can attend maybe some socials, and actually come along and say, look, I want to just present to you what kind of stuff we're doing, what kind of data there is. Maybe upskill the healthcare assistant, upskill the PPG, and say, look, these are some of the resources we've got, and you can see yourself being a massive asset. And you're not seen as someone just to refer on to and not be part of the team. So I think that question is about how do you embed into any team. It's really part of getting internalized. So I would start there. Try and get yourself a supervisor if you can, or peer supervision with some other link workers in your local area.
I have to say, like, I love Mohan on social. You're forever singing the praises and talk. You know, I obviously Razor one I know well because he's your right hand man. But you know, it's lovely the way, you know, you're a team, aren't you? And you know, you support each other, and he's so embedded with you and your practice and your patients. He's you know, so it's lovely to see.
Yeah, there's a few people echoing that as well. Simon says making link workers part of the overall health team at the practice is vital. So definitely echoes what you had said there. So what we're going to do is we're going to round up. As I mentioned, we have a lot of questions coming on thick and fast, but we will get back to you within the next 24 hours. What we're going to get out to you tomorrow morning is a link to the recording, the original slides, and as mentioned, the YouTube video that Mohan was talking about in order to send as an asset. We want to say thank you so much to everybody that joined us this afternoon. Apologies about the slight time change last week. I know there's a few that couldn't make it today, but as I said, we'll have the recording out tomorrow. So thank you so much, everyone. Mohan, thank you so much for joining us today. We really appreciate it. And Paul, thank you so much as well. Folks, have a lovely afternoon, and we'll speak to you all again soon.
Thanks, everyone. Thank you. Bye.
Thanks, everyone. Thanks a lot.
Bye.